Hello everyone. In this session on environmental emergencies, let's learn about high altitude disorders or high altitude illnesses. You might get questions regarding high altitude syndromes, especially acute mountain sickness, HACE as well as HAPE. Alright, so let's cover some of the basic concepts before going into the syndromes. Alright, so we'll be discussing about the physiology as well as pathophysiology of acute mountain sickness. Then we'll see the high altitude syndromes in detail and some of the other altitude syndromes. Okay. Now, the main problem or the main culprit behind the pathophysiology of high altitude illnesses is, of course, hypoxia. There is just not enough oxygen up there. All right. Now, the problem here is that the fraction of oxygen in the atmosphere there is the same as down here as well. It's around 21%. But the partial pressure of the oxygen is too low. We know that for breathing to happen, we need to have the partial pressure gradient, right? The pressure gradient should be there to drive the oxygen into the lungs as well as across the alveolar capillary membrane into the blood vessels as well as the RBC, right? This pressure is on the lower side there, resulting in decreased oxygenation of the alveoli as well as the blood, all right, resulting in hypoxia. So all the clinical features are due to hypoxia, which is because of the hypobaric condition there at the high altitude. Now, we can grade the altitude based on the height in feet or even in meters. All right. So, intermediate altitude is 5,000 to 8,000 feet. At this height itself, there will be a decrease in the exercise performance as well as increased alveolar ventilation will be happening. Now, acute mountain sickness usually occurs at the altitude of 7,000 to 8,000 feet. All right. When we say high altitude, it's actually more than 8,000 feet. Okay. Or 2,440 meters. In order to convert feet to meters, you just have to divide it by 3.3. Okay. Feet divided by 3.3 will give you the meters. Okay. Now, there will be marked hypoxemia from 8,000 to 14,000 feet. Then, very high altitude is said when you go around or above 14,000 feet to 18,000 feet. And it is extreme altitude when you go beyond 18,000 feet. Okay. Now, let's see the physiology and pathophysiology of altitude acclimatization. All right. See, all people going to high altitudes do not die because of hypoxemia. All right. If you are ascending in a rapid manner, it can be much more worrisome or it can be much more dangerous. But if you are ascending in a graded manner, giving adequate time for acclimatization, hypoxemia, even up to 60% of saturation, can be tolerated by many of these people. Okay. Now, acclimatization happens in the ventilation. There will be changes in the blood, in the fluid balance, in the cardiovascular system, in the exercise capacity. Then there is, of course, a limitation to acclimatization. So they will be having symptoms. Even people living at very high altitude, they can have problems, even if because of there is a limit in the acclimatization. Okay. Then sleep at the high altitude. Let's look at each of these parameters. Okay. Now, the most important parameter responsible for acclimatization is something called as a ventilation acclimatization. All right. As we go up, the respiratory rate increases because of hypoxemia. All right. Hypoxemia or hypoxia will stimulate the carotid body. All right. And it causes the respiratory center stimulation there, and it increases the ventilation, trying to get more oxygen into the lungs. Because the partial pressure is low, we are trying to increase our respiratory rate to try and get more and more oxygen into our alveoli. All right. Now, this improves the hypoxia. All right. But the problem is that whenever we breathe faster, there will be carbon dioxide washout. So there will be respiratory alkalosis. We know that carbon dioxide is one of the principal stimulants of the respiratory center. So whenever there is a washout in carbon dioxide, this ventilatory response get blunted. All right. So we have a limit to hyperventilation. Trying to get more and more oxygen, there is a limit to that. All right. Now, When we give enough time, this limit is reset. Okay, so we will be able to tolerate lower levels of carbon dioxide level, and we will be able to increase our ventilatory rate even further by acclimatization. All right. Now, acetazolamide is a drug which can help us with this acclimatization. Okay, how it helps us is that it actually interferes at this step. Okay, it causes a something called as a bicarbonate diuresis. So we are losing bicarbonate from the body, or it enhances bicarbonate loss from the kidneys. All right, so it creates a metabolic acidosis. So there will be a compensatory increase in ventilation to blow out the carbon dioxide so that the pH can be normalized. All right, so acetazolamide helps to increase or improve the acclimatization rate here. Okay, then chronic hypoxic patients, they are at higher risk because they will be having a lower respiratory drive. All right, now just take a look at this table here. You can see the saturation level as well as the PO2 level drastically drops as the altitude increases, and you can see also the PaCO2 level also drastically drops. All right, so in order to see whether the patient has completely acclimatized, you can look at the PCO2 value. All right, it should be matching with the corresponding altitude. Okay, so this is the maximum acclimatization which is possible, maximum PCO2 that can be achieved at this particular altitude. Now, if the patient has not reached that much PCO2, that means acclimatization has not been completed. Okay, yeah, this is what we have already mentioned. Ventilation acclimatization, the physiology behind that. Hypoxia causes hyperventilation, which in turn causes respiratory alkalosis because of carbon dioxide washout. Okay, carbon dioxide is can form carbonic acid, which is an acid. So carbon dioxide washout causes respiratory alkalosis. Okay, in order to compensate for that, there will be renal excretion of bicarbonate. This is a normal phenomena happening. Okay, now, when you excrete bicarbonate, the pH returns to normal, and hence the patient will be able to increase the ventilation rate further. Okay. Now, after acclimatization happens, the central chemoreceptors reset to progressively lower PCO2 levels. All right. Now, acetazolamide accelerates this process. It causes bicarbonate diuresis. Okay. Bicarbonate diuresis. See, acetazolamide is a carbonic anhydrase enzyme inhibitor. All right. So, inhibiting this enzyme causes less reabsorption of bicarbonate into our body and more renal loss of bicarbonates. All right. So, this is enhancing the bicarbonate elimination from the body, gets the pH normal faster so that you can tolerate much more or create much more hyperventilation. Okay. Now, in the blood, there will be an increase in the erythropoietin level within hours of reaching the high altitude. The red cell mass increases over days to week, but it doesn't have much role in the initial acclimatization. All right. Now, the chronic mountain polycythemia, it usually occurs after weeks to months of time. All right. There will be an increase in the 2,3 dpg level, which shifts the oxygen dissociation curve to the right, but the respiratory alkalosis shift the ODC to the left. So there won't be much change in the normal ODC as such. Okay. Now, the fluid balance is something which we need to be knowing about. Now, whenever there is hypothermia, there will be peripheral vasoconstriction. So it increases or diverts the blood to the central core, right? Central body part, the trunk. Now, this increase in the blood will stimulate the baroreceptors there, and this will decrease the ADH as well as aldosterone level in the blood. All right, causing a natural cold-induced diuresis. Okay, cold-induced diuresis. Now, this will decrease the plasma level in our body, and it will actually cause hyperosmolality plus hemoconcentration. Now, because of this hemoconcentration, this is a natural phenomena happening. The blood will be able to carry more oxygen, right? Now, suppose if the patient is developing antidiuresis, All right. Instead of the diuretic cold-induced diuresis, now the patient is having antidiuresis. That is a hallmark that the patient is going in for acute mountain sickness. Okay. So this has to be very carefully considered. Okay. Now in the cardiovascular system, the stroke volume decreases because of hypoxemia, but the heart rate increases to maintain the cardiac output. The BP will be slightly increased, but the most important thing that we need to be knowing about is pulmonary vasoconstriction because of hypoxemia. Hypoxemic pulmonary vasoconstriction. Okay, that's the normal response of the pulmonary vessels. Now, whenever there is severe vasoconstriction there, it will increase the pulmonary vascular resistance and hence the pulmonary artery pressure. Now, this will result in the capillary leakage from the pulmonary vessels, which is the reason for development of HAPE. HAPE is high altitude pulmonary edema. Okay. Now, in the cerebral blood vessels, the flow actually increases transiently because cerebral vasodilatation there. Hypoxemia causes cerebral vasodilatation, whereas it causes pulmonary vasoconstriction. All right. Now, the exercise capacity is dramatically reduced. There will be 10% drop for every 1000-meter altitude gained above 1500 meters. Okay. Now, I already mentioned there are limits to acclimatization. So, people living at high altitude, even they can experience problems related to that, including weight loss, lethargy, poor quality of sleep, weakness, and chronic headache. Now, sleeping at high altitude, it's not very peaceful thing. All right. Your sleep is frequently disturbed. Okay. You can have frequent nighttime awakenings. The breathing pattern it's itself disturbed or altered. Okay. You can have chain stalk respiration with apneic pauses that can reach up to 20 seconds in extreme altitudes. All right. Now, it also improves with acclimatization, and also acetazolamide also helps you get the sleep pattern normalized. Now let's move on to the high altitude syndromes. These include acute hypoxia, acute mountain sickness, HAPE, HACE, then other altitude syndromes which include retinopathy, cerebral edema, sleeping problems. Then a group of neurological syndromes can develop. Now, the fundamental pathophysiology behind all this, or the etiology behind all this, is of course hypoxia. And all these conditions is seen in people who have a rapid ascent in unacclimatized conditions. All right. Now, all these patients can be treated with rapid descent as well as oxygen. Okay. So, these are the criteria for diagnosis of any high altitude syndromes. Okay. Now, acute hypoxia, it occurs when you have sudden ascent and there is severe hypoxic insult. Okay, you are ascending very rapidly, then acute hypoxia can result. All right. The signs and symptoms can include dizziness, lightheadedness, dimmed vision, and loss of consciousness can happen. And when the saturation drops to even 50 to 60%. All right. Now, the treatment, of course, as already mentioned, is oxygen, rapid descent, and correction of the underlying cause. Okay. So, do not ascend further, go down immediately, or if the descent is not immediately possible, you need to provide them with oxygen. Okay. Now, acute mountain sickness as well as haze are part of a single spectrum. All right. Acute mountain sickness is also because of cerebral edema, but in a much milder form. All right. Okay. So, what's the differentiating feature between acute mountain sickness and cerebral edema is a level of consciousness. Okay, there won't be any disturbance in the consciousness level in acute mountain sickness. When it progresses to that level, it is called as haze. Okay. Now, usually acute mountain sickness is seen in people who have more gradual and less severe hypoxic insult. And the clinical manifestations can include headache, nausea, vomiting, dizziness, fatigue, and sleep disturbances. All right. Now, it also depends on the rate of ascent as well as the sleep altitude. All right. Now, if you ascend faster and sleep at very high altitude initially itself, it's going to be much more common there. Okay. Then there is also a genetic susceptibility. Obesity is another risk factor. Now, pathophysiology here is hypobaric hypoxia causing cerebral vasodilatation leading to vasogenic edema. Okay. So vasogenic edema is the cause there, okay, due to cerebral vasodilatation. Now, the clinical features, it's usually seen when there is rapid ascent more than 2000 meters of altitude. On arrival itself, patients might be having lightheadedness and slight breathlessness. But the characteristic symptoms are usually seen after 1 to 6 hours of arrival there, and it can be even delayed up to 1 to 2 days. Okay. Now, the patient can have headache, which is usually bifrontal, worsening with exertion or even bending over or with any Valsalva maneuvers. Okay. Now, GI symptoms like anorexia, nausea, vomiting can be there. Then lassitude and extreme weakness will be there. Then irritability, sleepiness, deep inner chills, all these are signs of acute mountain sickness. All right. Now, there is a criteria or a self questionnaire to diagnose this condition as well as to determine the severity of acute mountain sickness. It's called the Lake Lewis AMS self questionnaire. Okay, the symptoms or the clinical features they are looking for are headache, GI symptoms, fatigue and weakness, dizzy or lightheadedness, and difficulty sleeping. And based on the score that they are getting, it can be divided into mild AMS, moderate AMS, or severe AMS. All right. Now, the vital signs are usually normal in AMS patients. The saturation will also be normal or slightly on the lower sides. Okay. Most of these patients can also have high altitude pulmonary edema. So, local CREPS might be present in about 20% of patients. Now, this can last for many hours to days or even to weeks. All right. Now, if these patients develop ataxia or any altered level of consciousness, now it has progressed to high altitude cerebral edema or HACE. Okay. Now, the treatment of AMS, the goals of treatment are to prevent the progression of the symptoms, treat the symptoms, and to hasten acclimatization. Okay. Now, there are three principles behind the management of these patients. Do not proceed to higher sleeping altitude in the presence of symptoms. All right. Do not climb further. All right. Then descent if symptoms do not abate or become worse despite treatment. Okay, you can give medication, medical therapy, but if it doesn't improve, you have to descend. All right, because descent is the definitive treatment. Now, descend and treat immediately in the presence of symptoms of HACE or HAPE. There is no confusion there. If there is HACE or HAPE, you have to descend. All right. Now, mild AMS, okay, the same principles apply here. No further descent, descent to lower altitude or acclimatization at the same altitude. These are the options. And medical therapy for acclimatization or accelerating acclimatization is acetazolamide 125 milligram BD. Okay, sometimes in some people you can give even up to 250 milligram BD. Okay, to speed acclimatization. Now, symptomatic treatment, as necessary with analgesics and antiemetics, may also be given. In moderate to severe cases, immediate descent if the symptoms worsen. Low flow oxygen is helpful if it is available. Then again, acetazolamide. If the patient cannot be descended, then if you have hyperbaric therapy, portable hyperbaric bags with you, you can use that as well. Now, high altitude cerebral edema and high altitude pulmonary edema we will discuss. Now, the option of descent and oxygen, it is the optimal therapy for moderate to severe AMS. Okay. Now, a drop in altitude of 300 to 1000 meters may be required for these patients for improvement to occur. Now, otherwise, you have the option of using portable hyperbaric bags, or what you're seeing here is the portable hyperbaric bag. All right. Then oxygen can relieve the headache as well as dizziness, and these patients can be given nocturnal oxygen as well, because during sleep hours the respiration can be really compromised. All right. And nocturnal oxygen will help to accelerate the acclimatization. Okay. Now, medical therapy, there is a role in mild to moderate cases of AMS only. Acetazolamide is the drug of choice. We have already mentioned that it is a carbonic anhydrase inhibitor, causes bicarbonate diuresis, whereby it stimulates the ventilation. Okay. Now, it can help to maintain the cerebral blood flow despite greater hypocapnia. Dose is 125 milligram BD. Then the adverse effects of acetazolamide are peripheral paresthesia, nausea, vomiting. Then sulfur allergy patients should not be given this, and sometimes in rare cases, even Stevens-Johnson syndrome has been reported. Okay, remember that about acetazolamide. All right. Then symptomatic treatment, I have already mentioned. Then in moderate to severe cases, there might be a role for dexamethasone. 4 milligram every 6th hourly may be given. Okay, along with acetazolamide. Prevention is the best method here. All right, prevention of AMS is always, or prevention of any high altitude illness is the best method to follow. Okay, so for that, graded ascent with adequate time for acclimatization is the key. Okay, avoid overexertion, alcohol, and other respiratory depressants. Acetazolamide may help to prevent AMS. All right, it is a standard of care treatment for prevention of AMS. Okay, it enhances the ventilatory acclimatization, and it should be started 24 hours before the ascent and continued for 2 days at the high altitude. Okay, now dexamethasone may also help. 4 milligram BD may be given and continue for 2 days. Ibuprofen can help with the headache related to acute mountain sickness. Acetaminophen has also have shown in some studies that it can help to prevent acute mountain sickness. And even ginkgo biloba, it's a natural alternative for all these medications for prevention of acute mountain sickness. Exact mechanism of action is not clear yet. Now let's move on to high altitude cerebral edema, which is the much more severe form of, or the severe spectrum of the acute mountain sickness. All right. Now, altered mental status, ataxia, stupor, and progression to coma can happen if they are untreated. Okay. Raised ICP with involvement of cranial nerves 3 and 6 may be seen. HAPE will be usually present. Pulmonary edema will be usually associated in about 50% of these cases. Now, the treatment is, of course, oxygen, descent, and steroidal therapy. That's the key. Okay. Of this, descent has the highest priority. All patients with HACE should have rapid descent. If they cannot descend, then go for oxygen therapy, steroids, and portable hyperbaric bag if it's available. Okay. Then acetazolamide can also help in the treatment. Of course, DDs of all altered mental status conditions are there, like encephalitis, meningitis, stroke, or SAH. Okay. Now, is there any role for diuretics, mannitol, or hypertonic saline? Actually, there is no adequate evidence to suggest that. And the coma, once it has happened in HACE, can even persist for many days. And if you get an MRI for these patients, you can see hyperintensities in the white matter because of white matter edema in the T2 images. Particularly, this is seen in the splenium portion of corpus callosum. Okay, in the splenium. Okay, remember that. White matter, hyperintensities because of edema there. All right. Now, high altitude pulmonary edema. This is easily reversible with descent and oxygen. That's a common theme here. Treatment of any of these conditions is descent as well as oxygen. Okay. Now, it has resulted in more death than HACE. Okay, because it can cause respiratory failure and hypoxic respiratory failure as well as death. Okay. Now, the risk factors are heavy exertion, rapid ascent, cold, excessive salt ingestion, use of respiratory depressants, previous history of pulmonary edema, then pulmonary hypertension patients. Okay. Now, the pathophysiology, this is a non-cardiogenic pulmonary edema. The left ventricular function is usually very much normal. Now, the edema here is because of the high or markedly elevated pulmonary artery resistance and the pressure there. All right. There will be high microvascular pressure resulting in the capillary leakage there. Differential diagnosis, of course, includes respiratory infections, pulmonary embolism, and heart failure. Now, in early stages, the patients usually present with dry cough, decreased exercise performance, dyspnea on exertion, increased recovery time from exercise. All right. So, any patients with dyspnea on exertion or a dry cough, you need to suspect HAPE from happening. All right. Now, there can be localized rails. There can be a drop in the resting saturation of these patients by about 10 to 20%. Now, in the late stages, there can be signs of respiratory failure. There will be tachycardia, tachypnea, dyspnea even at rest. Marked weakness may be there, productive cough, generalized rails, and even altered mental status. Okay. Now, it usually gets worsened at the night time, on or after the second night at a new altitude. Okay. Now, on examination, you might get a prominent P2 and right ventricular heave. Chest X-ray may be localized to generalized alveolar infiltrates. Okay. Now, HAPE treatment is again immediate descent is the treatment of choice. Oxygen supplementation immediately lowers the pulmonary artery pressure, but it takes around 36 to 72 hours of oxygen therapy for complete resolution to happen. Okay, so there is a role for portable hyperbaric bags. Then keep the patient warm because cold can induce stress and further increase in the pulmonary artery pressure. In mild cases, bed rest might be enough, but in moderate cases, bed rest plus oxygen, if these patients cannot be descended, may be enough. But in severe cases, descent plus oxygen, and after descent, hospitalization has to be done. Okay. Now, there might be a role for sildenafil because these are also phosphodiesterase inhibitors can reduce the pulmonary vasoconstriction, reduce the pulmonary hypertension there, and there might be a role for nifedipine as well. Okay. Now, HAPE prevention or prophylaxis, we can give nifedipine, which is a calcium channel blocker. 20 milligram TID may be given, or sildenafil or tadalafil. Tadalafil, 10 milligram BID may be given, and salmeterol may be given to reduce the bronchoconstriction twice a day. All right. Now, this is a chart highlighting all the treatment options in high altitude illnesses, including acetazolamide, dexamethasone, tadalafil, as well as nifedipine. Just go through this chart. All right. Now, what are the other altitude syndromes? There can be peripheral edema, but it usually spontaneously resolves by descent. There might be a role for diuretics. Then high altitude retinopathy with retinal edema, hemorrhage, dilatation can happen, but usually they resolve in next 10 to 14 days of descent. Okay. Then patients can have high altitude bronchitis with dry and hacking type of cough. Salbutamol MDI can help to relieve that. All right. Then there is some entity called as chronic mountain sickness or chronic mountain polycythemia. It is also called as Monk's disease. All right. So Monk's disease is chronic mountain sickness or chronic mountain polycythemia. There will be excessive polycythemia. Hemoglobin will be more than 20 grams per deciliter. All right. And because of this, patients can have headache, muddled thinking, deep difficulty in sleeping. Then chest congestion could be there. And treatment includes phlebotomy, relocation to a lower altitude, home oxygen, acetazolamide, and even medroxyprogesterone acetate has shown to help. All right. So those are the things we need to be knowing about high altitude conditions or high altitude disorders. Just let's have a quick recap. Remember the pathophysiology here as well as ventilatory acclimatization. It's very important. Remember the spectrum of conditions of acute mountain sickness to HACE. Most of these patients will be having HAPE as well. Definitive treatment is descent. Okay. Plus oxygen therapy plus acetazolamide to accelerate acclimatization. Okay. So those are the things which we need to be knowing about high altitude disorders. I wish you all the very best. Thank you.